everyone, welcome to this live session. The topic that we are going to talk about today is induction during labor, and we will be having with us Dr. Theertha. She's a practicing obstetrician and gynecologist. She will be joining us shortly. Hi, Dr. Theertha, I see you there. Um, I'll just try to get you in. Thank you so much for joining, everyone. Hello.
Hi,
Hi, Dr. Theertha.
how are you?
I'm good. How are you?
I'm good.
Thank you so much for joining us, taking time out and being here with us today. I'll just try to get in Vidya if she is available. Yeah, we can continue. Like once she is here, she will send me a request and I can include her. I'm Nilufer, by the way. This is the first time we are talking.
Yeah, I think the last time we spoke, there was some technical glitch and the
Yes.
session didn't go through.
Yeah, right. Yeah. Yeah, I just gave a brief introduction about you just before you joined. If there's something you would like to add, please go ahead and then we can continue with our question.
I'd just like to thank new mother.in. I mean, I am also a follower and I go through your posts and I think you guys are doing great work of putting content
Thank
out
you.
there, putting
Thank you so
reliable
much.
content and putting across the right information because social media is a place where information is also circulated. So I think great job and
Thank
thank
you
you
so much.
for inviting me. I hope if this session can help even one person, then it's worth it.
Thank you so much. Thank you so much for taking time out and joining us. I'm a big fan of yours, truly speaking. The way you inspire women, it's something like I'm inspired by you. So I am also a big follower and a fan of yours. Thank you so much for putting out, such inspiration-driven messages out there. It's really an inspiration to watch you. Thank you so much. I'll go ahead with our first question. So my first question is, what is induction? Like, what is
Okay.
it?
Before before I start explaining what is induction, we should know what exactly happens during labor. I've made a tiny drawing. Please excuse my drawing skills. This is your pregnant uterus. I'll show it with a specimen as well. This is the fetus, so-called fetus. Now there is a length to the cervix. There is an internal os and there is an external os. What first happens is the cervix softens. That is the early stages of labor. Then as the fetus starts coming down, this length starts diminishing. In medical terms, we call it effacement or shortening of the cervix. Hi. Okay, so I was just explaining what actually happens during labor. Okay, your cervix will shorten up. Then as the head starts pushing down, it will start dilating. That is the whole procedure. Means the uterus is contracting, pushing the fetus down. As it's pushing the fetus down, then the cervix will dilate. Okay. Now, many times what happens is, for some reason, the fetal head doesn't descend, or you don't have uterine contractions, and you have reached term. Now, what is term? There are various definitions for term pregnancy. As per the American Society, the guidelines that we take, anything after 37 weeks is called as term. Early term is 37 to 38 plus 6 days. After that, 39 to 39 plus 6 is full term. 40 to 41 plus 6 is late term, and anything beyond 42 weeks is post term. In India, as per Indian Council of Obstetrics and Gynaecology, it is in a low risk pregnant woman. You may induce the pregnant woman anytime after 39 weeks of gestation. So induction of labor is artificial initiation of uterine contractions in a pregnant woman who is not in labor to help her achieve a vaginal birth within 24 to 48 hours. That's what is the definition of induction of labor.
Okay, that was really clear. Thank you so much, Dr. Tirtha. I hope that was understood by everyone out there. Now, is it safe, is it safe to induce labor? Because if somebody is looking out for vaginal birth, then does it not make sense to wait for the contractions to start naturally rather than having some external thing do its work?
Okay, first of all, induction of labor should only be done when the benefits of delivering you outweighs the risks of continuation of pregnancy and causing any danger to the mother and the baby. There are specific indications for doing induction of labor. Plus, whenever you're induced, it is always in a hospital setting. You are not induced and you will never be sent back home. So it should be done in a hospital setting. It is always under the supervision of your obstetrician, and there is continuous maternal and fetal health monitoring. So induction of labor is absolutely safe, provided it is done for a legible indication, which is always the case.
Okay. Before, okay, can you, when we are saying that we are talking about induction of labor, you are explained with that diagram, that was very clear.
Hmm.
Um, can we, what exactly is the process? What happens during the induction? Like, when we say labor is being induced, what is the process?
Okay, so when will your obstetrician advise an induction? One is when you're post dated, like your expected date of delivery has passed. So, and the duration of pregnancy, many people tell we are already 9 months. Why haven't we delivered? First of all, your duration is 9 months and 7 days. That has to be clear. That is 40 weeks. We don't have 4 weeks in a month. We always have 4 weeks and plus 2 or plus 3 days. That
Right.
maths calculation is a little difficult for some people, so leave it to your obstetrician. So once you've crossed 40 weeks, if everything is fine but you've still not gone into labor, then they will ask you, probably they'll do a clinical examination, do a per vaginal examination. They might ask for an ultrasound to screen for the Liker, that is your amniotic fluid volume, and the weight of the baby. Because many times after 40 weeks, what happens is that amniotic fluid starts diminishing and the baby's weight starts increasing. Apart from that, if you have any medical conditions, like if you are a hypertensive during pregnancy, if you have gestational hypertension, or if you have gestational diabetes mellitus, these are the indications when they might advise you to go ahead, that we should not delay it because it may cause danger to the mother or the baby. Or if you have pre-labor rupture of membranes, I think your last live session was water breaking. If your water breaks, that means the barrier between the baby and the atmosphere is broken. So that is when they consider whether to induce you. What if they have advised you, you can ask as many questions as you want as to what is the cervical status, what is the status of the membranes, what is the weight of the baby, whether your cervix is dilated or not, what are the possibilities that you may achieve vaginal delivery. Once you ask these questions and they have been clarified, then for induction of labor a consent is taken explaining the risks and the benefits. Then after the clinical examination, and there's a non-stress test which is done. Non-stress test is a graph. You can in layman's terms we can call it as the ECG of the fetus, where the baby's heartbeat is charted along with uterine contractions and the fetal movements. And we have certain parameters which we check, and we either label it as reactive or non-reactive. Once the reactive NST has been achieved, now coming to the methods. There are various methods of induction of labor, namely mechanical, there is medical, and then there is surgical. Now, mechanical method is if you are even slightly dilated, like if my tip is going or if your one finger dilated, then there is a instrument which comes called as the Foley's catheter, which usually we use where we put in the catheter inside. It has a bulb. Okay. It's put, I'll show you. It's put inside and there is, oh sorry, it's put inside. If I draw it, it's like this. Okay, it's a catheter. Basically, it's used for, it's artificial catheterization it's used for, but this is also one of the indications where it can be used. There is a bulb here where about, 8 to 10 cc of normal saline is injected, and we pull it and we tie it to the mother's thigh. And because of the mechanical stimulation, the cervix stretches, and as it dilates, the Foley's catheter will drop off. Okay, it is one of the safest methods because it is mechanical stimulation. We are not inducing, we are not putting any drug or medicine inside. The other method, that is the medical method, is we put a gel, we put prostaglandins, that is dinoprostol. Now, why do we get uterine contractions? Because prostaglandins are getting secreted. Prostaglandins, it is a very beautiful chemical. When you have menstrual cramps, that's where your prostaglandins are working. When you're having uterine contractions, that's when your prostaglandins are working. If you have excessive bleeding following delivery, that means your uterus is not contracted well, that is also when your doctor will give you prostaglandins. So it's a very beautiful chemical. Now, prostaglandins is dinoprostol, wherein the gel is inserted in the cervical canal here. And we wait for at least 6 hours and we see whether you start getting your uterine contractions. This is done if if your cervix is not dilated at all, like a tightly closed cervix, then it's put in your vagina. If you're slightly even little bit dilated, then it's put in the cervical canal. Okay. Apart from that, there is a drug called as oxytocin, or what we call as the love hormone. Now, oxytocin is helpful when your cervical length is slightly reduced or it's gone. What prostaglandins do is, cervix has collagen. They cause lysis of that collagen. So it has collagenollytic properties. So it causes the shortening. Once it's shortened, we can use a combined method. That is, we can start you with oxytocin, wherein it will help in the uterine contractions as well, and it will start dilating. Once it's dilated, then comes the surgical method. Surgical method is amniotomy, or what we call it as low rupture of membranes. Now that is when the baby's head has come down, you're about 3 centimeter dilated, you're getting good uterine contractions. So your doctor will examine you. So you'll see that the head is well applied on the cervix, the bag of membranes is below it. So she'll rupture it with an instrument called either amnio hook, or there is another instrument called as a Cocker's forceps. Once she ruptures it and she ensures that the liquor is drained, you will notice that the contractions become stronger. Okay, one is that. Other one is sweeping of membranes. Now what happens? There is a layer, there are membranes around. So you put your finger inside, we sweep it, so that again prostaglandins are released. So depending on what is the fetal station, what is the status of the cervix, the obstetrician picks up accordingly that method and gives you the opportunity to achieve a vaginal birth. I think that's about it. I spoke a lot.
That was lovely. It
Yeah,
covered so much, and that was really, really informative. Thank you so much for that, Dr. Theertha.
that
Then,
that's why I didn't. Yeah,
yeah,
that's why I didn't feel like interrupting. I mean, talking anything. I was just listening to you.
Thank you.
yeah. Dr. Theertha, before we move on to our next question, there have been so many questions that have been coming in from the viewers. So I'm just going to read out a few of them, and then we can go back to our own questions. So Tanya is asking that today her doctor suggested her to use castor oil. Now she's not really said how, where, what. Yeah, that's what I do like. That's kind of a comment. So if you want to answer to that, please.
I was
I
kind of expecting this
Yeah, I just
question.
found out. Yeah, even I was asked to drink castor oil,
Castor oil.
either with tea or
Yeah.
yeah, mix it with something.
So what castor oil basically does, in local language, it's called erandal ka tel. So because you can't drink it by itself, because it's an oil and it's really viscous and thick, that is why you are asked to usually dilute that like about 20 ml in either milk or juice or whatever it is. It causes loose motions. It basically helps opening up in all the orifices. So it's thought that along with that, it will initiate uterine contractions. Like it will help with opening of the cervix as well. Now there is not enough scientific evidence to, like, you know, propagate it or tell that, you know, there is evidence regarding this, but it is the personal experience of many people, and it is a safe method of induction. If you know, if you are already told that you might have loose motions with it, that is the only side effect that has been noted with castor oil, and that it is not very palatable. Many people don't like the taste of it, but it has been shown to initiate uterine contractions. There is no evidence, but it is not something that has been found to be harmful as well for the fetus or the mother. So you
Okay,
can do
thank you.
it.
Thank you for that, Dr. Devta. There's one more question. Like, you know, it was like I received that question in the stories, and it looked quite interesting. So I'm reading it out to you. So I don't know her name, but she's asking that she's already had her baby, okay, and what happened with her is that her doctor did the sweeping of membranes. uh, she has not mentioned in which week she was, but she says that the sweeping of membranes was done, and it was not really discussed, I guess. So her question is like, you know, uh, is it necessary? Like, and she did not have any complications as such. So is it necessary, or like, you know, the consent of the patient is not required before inducing, because it's kind of inducing labor, right?
Hmm. So what usually happens is when you go for your regular antenatal checkup, right? After 39 weeks of gestation, if a finger is, or if your cervix is admitting a single finger, your obstetrician should explain obviously that I will sweep, you might get contractions, and you should be in the vicinity. If I'm sending you home, sweeping of membranes is, you know, you are separating the membranes from the lower uterine segment around the cervix. So one, you might have some spotting. Two, it is not 100% that you will go into labor. So from 39 weeks of gestation, probably if she swept you once, then you might take, say, about a week or 10 days. That is also possible for you to start getting uterine
Okay.
contraction. But what happens is you're getting that window of going into labor naturally,
Okay.
spontaneously rather. Natural is not the word that we should use. When they sweep you, then you get that window, and there is a possibility that your cervix will shorten naturally, the spontaneously, and the head will come down by itself. So if
Okay.
she's taken a verbal consent, then it's okay. For a sweeping of membranes, that at that particular point in the outpatient department, she might not have taken a written consent. Whenever medical methods get involved, that's when we have to admit you, because, you know, anything can happen. How you
Okay.
respond to the drug, it's very unreliable. While sweeping, it again comes under, it's partly mechanical surgical method. Okay. So
Okay.
if she's told you what is going to happen, if she's already told you that you should be in the vicinity, that is most important. So that even if you have a little bit contraction, you can immediately come down to the hospital. It's not necessary that you have to be admitted, because again, staying admitted in the hospital for like a week or 10 days is not feasible. So that is why.
Right. Okay, there's another question. It's from Siddhana. Can labor be induced naturally without medical intervention?
The definition of induction is initiation of contractions artificially. So induction of labor cannot be done naturally, or like I always tell that please don't use this word natural. Anybody who has an abdominal birth, they don't have horns on their head that they've undergone a C-section, you know. They are also very normal. So it should be abdominal birth or vaginal birth. Usually after say 38, 39 weeks, you can start doing your walking, the squats, the exercises, pelvic floor exercises that help in opening up your pelvis, so that by gravity probably the head descends down. So these are the methods that you can try, but they will induce labor 100%. Nobody can, tell you that no, if you do this, you will go into labor definitely.
Yeah. Yeah, thank you, Dr. Theertha. Vidya, you want to continue with the question?
Yeah, I have one question. Dr. Tita, will all the methods be used, or will it be required? If required, will it be used for inducing labor? Like if one doesn't work, we have to try another way or something.
Okay, so first of all, depending upon the status of the cervix, the presenting part, that is the station of the head, how much are you dilated, how thin is your cervix, that is how short is your cervix. These are the parameters. What is the status of your water, like what is the status of the membranes, are they there, have they ruptured, what is the weight of the baby, is the maternal parameters normal, like the pulse, blood pressure, is she okay, are the uterine contractions good? Now this is another question that is usually asked, what are good uterine contractions? Now good uterine contractions are when you have 2 to 3 uterine contractions that are lasting for 40 to 45 seconds in a matter of 10 minutes. These are good uterine contractions. If you're having good uterine contractions, the head is descending well. Like I said, if the cervix is tightly closed, then we prefer using prostaglandins, which is put in the vagina. If the cervix is slightly open, but the length is still there, then either a Foley's or putting the prostaglandins in the cervical canal. If the cervix has shortened and has slightly opened up, then it's oxytocin, because we need uterine contractions now. And afterwards, when you're around 4 centimeter dilated, the head is come down nicely, then we do the amniotomy or the artificial rupture of membranes. So these are the methods. So everything is not used all the time. Depending upon what is the situation, clinical scenario, that is when a specific method is used.
Okay. Yeah. Yeah, there's one more comment. It's from, I guess, the previous person only. She says that I'm in 38 weeks waiting for head enrichment. Due to previous C-section, I'm advised not to get induced.
Okay. So now this is a very interesting question, and I'm happy that this was asked. Majority of the times, the scar on the uterus is usually this is your uterus. Okay, ignore the baby. So there is a low transverse incision, which is majority of the times made in the lower uterine segment. Very rarely it is a classical, that is, your uterus is either cut like this for opening the uterus and bringing the baby out. Now when is this used? That is if there is a fibroid sitting right here, where the approach is not possible only. You can't get the baby out like that. So it's either a vertical, this is a classical cesarean section, which is rarely used, or it's an inverted T-shaped incision. Okay. So what happens is your lower uterine segment, there are two segments which usually happen in labor, lower uterine segment, upper uterine segment. Your lower uterine segment heals very well. It has good healing power, whereas the upper uterine segment scar, the healing does not happen that effectively. Okay. So, and first of all, there is a saying which a scarred uterus is always a scarred uterus. That is why inter-pregnancy interval of a minimum of 18 months is very important if you plan to go for, spontaneous labor with a previous C-section. Ensure that there is a gap of 18 months minimum. Okay, and it is preferable if you've had a previous cesarean section, if you come in spontaneously in labor, that is preferable to induction of labor, because when you induce, it automatically puts you at risk of uterine rupture. Now statistically, anybody who has a previous C-section and goes into labor, 60% of them will deliver vaginally. That is the statistics that is present. 40% will go for a repeat cesarean section. And for these women, mechanical method, if you want to go in for induction, mechanical method is the safest. And following that, the next method is oxytocin. Prostaglandins is not advisable because it increases the risk of uterine contractions. Okay, so taking into consideration all these factors, what was the indication for the previous cesarean section? Why was the previous cesarean section done? What is the status of your cervix? Where is your fetal head? It's not engaged. So probably the obstetrician thinks that it might not get engaged in labor also. Okay, maybe your cervix is tightly closed. So that is why that doctor must be recommending what was your clinical history. We don't know. What are your, associated risk factors? We don't know. And again, in India now is the scenario that many women plan to have only 2 children, and we want both children alive. We want both children healthy. Whether you're ready to take that risk of uterine rupture, that is the biggest question that comes in. You should deliver in a setup which has emergency facilities, where your anesthetist is available, where your pediatrician is available, and your obstetrician is available. All three of them are available together, where there are blood bank facilities available, so that if anything goes wrong, you can be taken in for an emergency C-section immediately. And the next is continuous maternal and fetal monitoring facilities are available. If these prerequisites are met, then you can discuss with your obstetrician that I want to try for an induction, taking into consideration all the risk factors. That is.
Yeah, thank you so much, Dr. Theertha. That was a very detailed reply to that comment. Yeah. We have another question. So this is from Neelam. She says, मैम अगर बच्चे के गले में कॉर्ड हो और बच्चा सांस नहीं ले पा रहा हो तो डिलीवरी के सबसे पहले बच्चे को कैसे बचाएं?
सिंगल लूप अभी आपने ये नहीं बताया है कि कितने कॉर्ड्स है. सिंगल लूप ऑफ कॉर्ड वो बच्चे के गले में माले की तरह होता है. आपको ये पता होना चाहिए कि कॉर्ड 30 सेंटीमीटर तक भी लंबा हो सकता है. 30 सेंटीमीटर से भी ज्यादा लंबा हो सकता है, क्योंकि वो प्लासेंटा से जुड़ा होता है और एक तरफ दूसरे बच्चे की नाल के पास जुड़ा होता है. तो सिंगल लूप हो तो इट विल बी लाइक अ गार्लैंड अराउंड द नेक, और उसमें वजाइनल डिलीवरी में कोई दिक्कत नहीं होगी. सिर्फ एक दिक्कत हो सकती है कि बच्चे का सिर थोड़ा नीचे आने में थोड़ा टाइम लगेगा, क्योंकि नाल है तो वो ऊपर लेके जाएगा. वजाइनल डिलीवरी हो जाती है एक सिंगल लूप ऑफ कॉर्ड में. अगर 2 लूप है, 2 बार बच्चे ने अपने गले में कॉर्ड को घुमाया है, तो बच्चे का हार्ट बीट मॉनिटर किया जाएगा. कंटिन्यूसली मॉनिटर होता है लेबर के टाइम पे भी. और अगर ड्रॉप हो रहा है, अगर डॉक्टर को लगता है कि बच्चे की सांस अटक रही है, तो वो आपको बोला जाएगा कि बच्चे को तकलीफ हो रही है, तो हमको तुरंत इसको डिलीवर करने की जरूरत है. बहुत ही रेयर सर्कमस्टांस होते हैं जिसमें 3 लूप्स होते हैं. वी हैव डिलीवर्ड, मतलब वजाइनल डिलीवरी उसमें भी पॉसिबल है, लेकिन बच्चे को कोई तकलीफ नहीं होनी चाहिए. उसका हार्ट रेट 100 के नीचे गिर रहा है बार बार. आपको जब भी पेन आता है, अगर 100 के नीचे जा रहा है, मतलब बच्चे को दिक्कत हो रही है. और ऐसा रहेगा तो तुरंत बच्चे को सी सेक्शन करके डिलीवर कराना जरूरी होता है. लेकिन फिर भी देखते हैं कि कितना उसका हार्ट रेट गिर रहा है, आपका डायलिटेशन क्या है, तुरंत डिलीवरी करा सकते हैं क्या कि नहीं. तो फिर
Thank you, Dr. Theertha. Thank you so much for that. Another question that we have is that during induction, okay, does it pain? The process, is the process painful? And the next question is, if the woman chooses to get induced for labor, will that vaginal delivery be more painful um, compared to the normal one? So 2 questions here. One is whether the process is painful and whether induction causes some extra pain in the vaginal delivery.
Okay, so one is only the initiation is artificially done. The rest your uterus has to take over. The contractions is caused by the uterus only. Now, if we go to say that there is the rare possibility, that is about 1% of uterine hyperstimulation. Sometimes if the drug has entered the uterus and hyperstimulation is, more than 5 uterine contractions in 10 minutes, or if your contraction is not subsiding within, say, 45 to 50 seconds, if it's present for more than 120 seconds, that is 2 minutes, that the possibility of that happening is 1%. Okay, so apart from that, the entire process is similar to what happens when you go into labor spontaneously. The process is, it's going to give you the same amount of pain that you would have gotten if you were going into labor spontaneously. Only the initiation is done artificially. So that is the question. And one more, there is one more myth that keeps getting circulated. Now, if you are experiencing more pain, like extreme pain, many times you are not mentally prepared that the labor pain are considered to be the worst pain anybody can experience ever. So epidural analgesia is a very effective method of pain relief. Many myths are circulated that if you take epidural analgesia, it reduces your chances of vaginal delivery. That is not true. It helps you in tolerating those pains, and it is an added advantage. Our ancestors did not have that advantage which we are having. So if you are unable to tolerate the pain, please don't think that you as a woman, your power is being questioned. These are the things that I've heard and I've seen, because you are judged. How you deliver your baby is completely up to you. It's your choice. You have taken pain and efforts of carrying this baby for 9 months, and if you are not able to tolerate the pain, epidural analgesia is giving you the added opportunity to help you achieve a vaginal birth. After that, there is no guarantee. There is no guarantee of life per se. But epidural analgesia is to help you. So please go ahead and take it. If you don't listen to anybody, prioritize yourself. Only the mother and the baby should be your priority.
Thank you so much for that motivation, Dr. Theertha. Yeah. Regarding epidural, I just had one question in my mind. So, if I have to take epidural, is there any time duration that I have to take it within this time, and I cannot take it after that? Maybe dilation,
Huh.
uh, till some level of dilation or anything. Like, is there any such consideration in case of epidural?
Okay. So initially, when epidural analgesia was newly advised or told in various conferences or various guidelines, they used to say that you should give epidural only when, sorry, a woman is 4 to 5 centimeter dilated. Because to increase the chance, because when she's 4 to 5 centimeter dilated, we are more sure, more confident that she will deliver vaginally. Rather, when she is 1 or 2 centimeter dilated, then giving the epidural did not make sense, was the argument that people used to give. But recent guidelines have suggested that if you want to take an epidural, even in early labor, then you can take latent. There is latent phase, there is active phase of labor. Now you have to be 10 centimeter dilated for the delivery to happen, for the fetal head to pass through your cervix. So active labor is after you achieve 6 centimeter dilatation. Okay. So, and before that is the latent phase. So current guidelines say that even if you want to take an epidural analgesia in the latent phase of labor, it is acceptable. So now there is no specific dilatation mentioned or any particular stage mentioned.
Okay, thank you for that, Dr. Theertha. There's one question, I just want to read this out. If you want to answer it. It's from Saundarya. She says that I'm in my 7th month of pregnancy. My stomach is getting tight frequently, but I have movements. So I don't know what, like, stomach is getting tight. I don't know if she means contractions by that.
I think she means Braxton Hicks contraction.
Yeah,
So
but
Saundarya, if your contractions is not causing any pain, tightening is very normal. Those are Braxton Hicks contractions. But if this tightening is giving you pain, like it can be like menstrual cramps, it can present as severe backache which is not subsiding. Now, if the back in pregnancy, backache is also common because the curvature of your spine slightly straightens out. So that is why you have that low backache during pregnancy. But if you have persistent backache, then think that you might be in preterm labor. And the baby movements. Now, how do you count baby movements? This is also a very common question. So if you are doubtful that is my baby movements adequate, now 7th and 8th month the baby will move a lot, because there is a lot of space for the baby to move. In the 9th month, the number of movements, there is less space, so the intensity decreases, but the number is the same. Let me be clear. So if you have a doubt, what you do is morning, afternoon, and in the night after your meals, breakfast, lunch, and dinner, sit quietly for an hour and count the movements of the baby and note it down. Keep a notebook with you if possible and note it down. So in the entire day, in those 3 hours, the total number of movements should be 10 or more than 10. In that one particular hour, that is minimum of 3. So 3, 3, 3, that is 9, round it up, 10 or more than 10. If you don't feel even one movement in that 1 hour, you eat something. We say usually have sweet, because the baby's response to glucose is quite fast. After that also, if you don't feel movements, then you think there is something wrong and go over to your obstetrician and tell them that I don't feel my baby's movements, and then they'll examine you, then they'll tell you the further procedure. Now if this tightening is not causing you any pain, it's Braxton Hicks, but if it is eliciting pain, then please go and meet your obstetrician.
Yeah, thank you so much for that, Dr. Tirtha. Yeah, also Soundarya, like, and everyone else, we also have a baby tracker. Like, it's a freebie that we have at New Mother. So if you just, go on to our website, you can download it for free. We just have it. It's a nice, cute sheet which you can download and track your baby's movement. Yeah.
Yes.
So, Vidya, do you have
Doc-
any question?
yeah. Yes. Dr. Tita, can sex also, act as an induction for labor?
Okay, sex. Previously, they used to say that sex can induce labor because it releases oxytocin. That's why it's called the love hormone and start contractions. But please, if you want to have sex, usually we until the 3rd month we usually say be careful. Plus, if your placenta is low lying, then we say wait until the 3rd month for the placenta to descend upwards. And from the 4th month to the 7th month, if you have a low risk pregnancy, then we say sex is advisable. After that, sex becomes little cumbersome, because I usually tell this to my patients also, like if you're carrying 3 kgs on your back all day long, it is going to be very tiring. Similar, that same thing you have in the front. So after the 7th month, it gets kind of difficult to have intercourse. If you're having intercourse, you can have, but please have it hygienically so that you don't introduce any infection. And just be careful to not be too aggressive. And if the placenta is low lying, if there is a cervical stitch, what we call as os tightening, if you are carrying a multiple gestation, then you have to be careful. These are the 3 places where you should be careful, but you can have sex. Now again, there is not much evidence to suggest that sex will induce labor definitely, but this is the explanation that has been given in some articles, that it may release oxytocin and initiate uterine contractions. So after your doctor says fine, after this, if you deliver, the baby is going to, you will not have any trouble, you can go ahead and have intercourse with the thought that you may have labor pains.
Okay.
Okay.
Okay. Last question, Dr. Tita. Do you have any suggestions or tips for mothers who are planning for induction
Okay.
for labor?
So, okay. So number one is please be mentally prepared. Like I mentioned earlier, labor pain it is going to be bad. Please remember that. Go with the thought that it's going to be bad. Then when you get it, you will be well prepared and you will be like, ठीक है, इतना खराब नहीं लग रहा है. Okay. So when it's like an exam, if you think that it's going to be bad and all the questions that you have come, then you'll be like, ठीक है, इतना खराब नहीं गया. So mental preparation is very important, and trust. This is always trust your obstetrician. Ask as many questions as you want. Your obstetrician is there to answer them, and they should answer them. And I don't think there is any obstetrician, apart from maybe a limited few, who will have any problems if you ask any number of questions. Ask. Don't keep any doubt in your head. You should not feel like, I did not ask this, that is why this has happened. So you don't have any regrets. And a strong support system. 3. whoever is your person you trust, whether it's your partner, whether it's your mother, whether it's your family, be it a friend, I always say prioritize yourself. If you don't, this is Indian scenario where a number of people will come and sit in your room and you are struggling in pain and you don't want it but you can't say it. So discuss this well in advance with your family, that when I am in labor, I do not want anybody in my room except this one particular person who will
Number
support
of
me.
people will come and sit in your room. I'm sorry. I'm like,
Yeah,
yeah, that happens.
exactly. So it is very annoying and you can't do anything. And at that particular point, you are not in that mental state where you can, either throw them out of the room or just you say anything. So prepare yourself, make that very clear in the very beginning that when I am in labor, I want only these many.
Yeah,
Audible?
that's yes,
Yes.
yes,
Okay.
yes.
And
Okay.
last but not the yeah, yeah. Last but not the least, if you can opt for pain relief if you are not able to tolerate the pain. That is the last and the final takeaway that you should take. And ultimately, everything, you have done your part. Your obstetrician has done your part. The remaining, I always tell this, that the baby decides what route it wants to come out through. So just trust your baby and yourself, and everything will go fine.
Thank you so
Nice.
much, Dr. Tita. That was beautiful. Like, beautiful closing line. Thank you
Yeah.
so much. Vidya, we're done with the questions, right?
Yes, yes, we are
Yeah.
done.
Thank
Thank
you
you
so
so
much.
much for joining us.
Yeah. It
And
was a
and
lovely session and really, really informative.
yes,
Thank you.
and we loved your diagram also.
Thank you. I tried.
Yeah. No, no,
Thank
it
you.
was it was helpful. Yeah. Thank you so much for joining us, everyone. And please don't forget to check out our freebies. The link is in the bio.
Yeah. Thank you. Bye.